Welcome everybody to the PSPS Diversity and Inclusion Committee. PSPS stands for Pacific Spine and Pain Society, and essentially, it's the most comprehensive organization with regards to pain management, neurosurgery, orthopedic spine surgery, physiatry, psychiatry, interventional pain. So it's a very comprehensive model where we collaboratively work on things that we could advance the field and empower each other and leverage each other's strengths to be able to provide great patient care. Welcome, everybody. Go ahead and hit the next slide, Rosa. Thank you. First and foremost, we definitely want to give a shout out to NALU Neurostimulation. NALU stands for WAVE, and WAVE, we mean it for with different waveforms. You see, neuromodulation is one of the therapies that we utilize to be able to manage chronic pain, either on the spinal cord itself, the dorsal root ganglion, or even the peripheral nerves. And so NALU is one of our partners. Very honored to share the space with them. Thank you so much for your sponsorship. And also thank you for your collaboration because meaningful difference between providers and industry is what really improves the space. So thank you for that. I'm going to go ahead and take the pleasure of introducing myself, and the rest of the panelists will introduce themselves as they're getting ready to speak. My name's Eric Cornelius. I come out of good old Tucson, Arizona. And yes, I do own cowboy boots and I wear them often. And yes, by the way, up in the corner here, you see Notorious B.I.G. So I also keep it real. I'm one of the owners of one of the largest pain practices in Southern Arizona. It's called the Pain Institute of Southern Arizona, and it's an organization that I love. We collaboratively make a significant difference in patients' lives, but we're also very involved with the community as well too. So all of you who are looking for a job, just make sure that whichever organization you decide to join does much more than just medicine, because we're also humans. We also take care of one another, and we all have to build each other up. So let's get to the next slide, which is the agenda. This is going to be the exciting stuff. So as you see, there's going to be a jam-packed agenda. There's so much that's going on, and you all are for a treat. We're going to first dive into just what is interventional pain management, just a basic overview. Then we're going to head off and discuss pathways to career in interventional pain management. In other words, what kind of training and fellowship opportunities are there in order for me to become an interventional pain specialist? And then let's dive into the day-to-day life, the clinical and procedural insights. What do we do on a daily basis? Last but not least, we'll talk about building your career. You could go into private practice, academia, getting involved with research. There's just so many different opportunities. So now this is when I'll discuss a couple of things. The next session will be Q&A. So make sure that all of you who have questions, please start typing your questions onto the chat, and towards the end, we'll be able to facilitate those questions. Other housekeeping item, that I want to discuss is that on the right upper hand side of your screen, you will see a QR code. That's for the survey. We want everybody to have a voice, and we really want to understand sort of what the temperature is when it comes to these kind of discussion points in our webinar. So make sure that if you hit that QR code, and if you have not participated in the survey just yet, please do so, because at the end of this webinar, we'll be announcing a winner for $100, and we could all use $100, right? One thing I will also mention is right before we get started is that we have two amazing student moderators who I've had the pleasure of just meeting and working with. And I will tell you what, I'm very optimistic about the future of medicine based on my interaction with these two individuals. So student doctors Rhoda Ijazi and also student Dr. Ankichita Kumar. So thank you so much. I'll give you a mad shout out for all the efforts that you put together. I just really feel like your dedication to this webinar just is an example of how much of an impact you will both make into this field. So with that being said, I'll let both of you introduce yourselves and also introduce some of your involvement in some of the organizations that made this webinar a success. I'll turn it over to you.
Thank you so much, Dr. Cornades, for that kind introduction. My name is Rhoda Hijazi. I'm a current third year medical student at Sam Houston State in the Houston area. I'll let Akanchita introduce herself and then we'll introduce a little bit more.
Hi, everyone. My name is Cheetah. I'm a third year at LMU DCOM, and we're both here on behalf of AOC PM&R and Representation in Rehab.
And we had the special opportunity to also collaborate with SNMA, LMSA, and the Medical Students with Disability Coalition. So we're very excited and happy to have been able to collaborate with several medical student groups who are all passionate about pain medicine, PM&R, and that different route of things. So we'll go ahead and get started for the sake of time. So our first section on our agenda is what is interventional pain management. So we have two lovely physicians here, Dr. G and Dr. Garcia. So we'll get started with the first question, which is what types of conditions are most commonly treated at interventional pain management? And this one was directed towards Dr. Garcia. And if y'all would like to introduce yourselves as well, please do so.
Hi, everyone. I'm Roxana, and I'm a current fellow over at Mayo, Arizona, but I did all my training up in the Bay Area. So I am so excited and really just happy to welcome the next generation of kind of medical professions. So interventional pain management, it's really broad, the conditions that are treated. I mean, it can range, from joint conditions, spine conditions like back pain, knee pain, shoulder pain, down to like lumbar radiculopathies, cervical radiculopathy, radiculopathies. That's a lot of nerve pain affecting the arms, the legs. And then we can also treat chronic regional pain syndrome. Sometimes we do injections even for like post-traumatic stress disorder, anything involving like peripheral nerves. It's a very complex field with a broad array of potential interventions and treatments.
Thank you so much, Dr. Garcia. I see a lot of questions coming in, so keep them coming in, but we will be answering those at the end. Our next question is for Dr. Cece. How does interventional pain differ from general pain medicine or anesthesiology?
Great question. So just to introduce myself real quick. So I'm Cece. I did my pain fellowship at Stanford and now I'm in the Los Angeles area. And so with interventional pain, there's a lot of specialties that have a little bit overlap with pain medicine. So there's some primary care specialties and other specialists who will can manage pain to a certain degree. They can depending on their training level, they can diagnose and maybe do some of the medication management. But what sets interventional pain specifically apart is, like the name suggests, the intervention part. So we do a lot of procedures and involves injections, whether injections in the back or in the joints. We also do what's called neuromodulation. So we can put whether temporary, permanent implantable devices in people's bodies and connect it either to their spinal cord or to peripheral nerves to treat their pain. We can also do things like ketamine infusions, lidocaine infusions, things like that to also help manage pain. So that's the main difference, is that we kind of go deeper into the intervention and the procedural aspect of pain management.
Awesome. Thank you so much. And this next question, both of y'all can answer, one of y'all can take it. What role does cultural humility or competency play in the patient-physician relationship in pain medicine?
So I think it's just very important to just have a diverse medical practitioner kind of group to begin with, right? We all know that there are certain groups that are disproportionately affected by like undertreatment of their pain. And so that has historically included like Black African American patients, Hispanic or Latino patients, and then often like older adults as well. And so I think this is kind of where people from diverse backgrounds can really play a huge role. I've also found that some patients from specific populations might have a really difficult time trusting physicians. And this is kind of where we, with our minimally invasive techniques, can help, create a really good patient-physician kind of provider relationship and, kind of get buy-in or kind of gain their trust kind of in the medical system. Before they can interact maybe with more invasive techniques. So for example, I've encountered that like a lot of people feel uncomfortable with surgery, right? If that's kind of being recommended to them, but they feel more comfortable kind of trying like an injection or quick procedure first. And so I think that's a big role where like a pain provider can kind of help begin that kind of relationship sort of with just medicine, like begin a relationship kind of based on trust.
And to add to that, so there's what's really helpful for minority physicians to get involved is when there's like a cultural barrier with patients. So some patients actually may not even believe that they need to do anything about their pain. Like there's different beliefs that may get involved in whether or not they're open to certain types of pain treatments. Language is a barrier, can be a barrier as well. And what can be really helpful is like if you understand the culture that they're coming from and how that plays a role in how they view their pain, then that's where like those with either understanding of that culture can step in and kind of be like almost kind of be a way kind of have a way of guiding them. So for example, there's some patients who like may not want to may not even feel like it's important to bring up their pain, and they just deal with it because their culture they're used to just kind of putting up with it until then it becomes an issue. So that's where it could be really helpful, where if like you have an understanding or if you learn to be confident in different cultures, that could be really helpful so you can help them optimize their pain management and their quality of life.
Thank you so much for that. That was really helpful. So we're going to start moving on into the next part of it, which is pathways to a career in interventional pain management. So have either of you encountered or overcome barriers related to identity or background during your training and as a part of your journey as a medical student, as a resident, and now for some of you as an attending?
I was like a first generation to college, to medical school, and my parents probably fall in the camp of people who distrust like Western medicine. And so I was try to straddle the lines of just their experience with medicine and then my experience. And so I wouldn't say that of course there are like systemic barriers of just barrier of entries to like medical school. But I think also just kind of personal barriers, just facing that right with my family, because even they to this day kind of distrust some pain physicians. So that was a big reason that I went into pain medicine, because I know that they live with a lot of chronic pain, and I want them to know that there are treatments out there, and I want to be one of those providers that can help kind of people like them. So I feel like those are some of the barriers I encountered, but like within pain medicine itself, I mean, I think people are like the applicant field to pain medicine is just changing really rapidly. So there's been a decrease in anesthesiology applicants. Like the pain field is just becoming more diverse in terms of like primary specialties that people are coming from. So like high amount of emergency medicine, psychiatry applicants, family medicine, et cetera. And so I think there's a big need and a big understanding within the field that kind of people from different backgrounds, whether that's in their primary specialty, culture, language, et cetera, can really come in and like help further the field along. So kind of within pain medicine, I haven't faced like any barriers. I mean, of course, like Cece and I can talk to about how there aren't many women in pain medicine, but I think everyone's just been really welcoming. And that's one of the reasons that kind of going to these society meetings and going to conferences has been really helpful for my career path.
Yeah, and just to piggyback back off that is, I don't think that there's no like big barriers that would stop anyone from entering pain medicine, but there can be challenges along the way, right? Especially like with we don't have as much of a diverse like physician population in pain medicine as we like, and just not seeing someone not seeing enough representation could influence someone's choice as they try to decide what field they go into. And also just naturally when it's not that diverse, you may experience discrimination, whether it's gender or racial discrimination along the way. And that's something I think we just naturally will like face in any field, not just pain medicine. But I will say, like, if any of you are considering pain medicine, definitely don't get discouraged. If anything, we need you guys in our field, because as we've alluded to earlier, it's really important to have like physicians of different backgrounds to be able to treat the patients of different backgrounds. And there's so many minorities who with chronic pain who experience a lot of disparities, and it's really helpful to have physicians of similar backgrounds to be their biggest advocate.
Thank you both so much for those inspiring answers. Next question, just from, I guess, our perspective in terms of pathway to pursuing a career like y'all have, what advice do you have for medical students or residents who are pursuing pain management or interventional pain fellowship? And what advice would you give your younger self starting off in these positions?
I would focus just on trying to be the best physician that you can, period. I think that that's sort of where it begins. And then making sure that, of course, you're happy and healthy as you can be throughout this. Because it is a long journey, right? You're going through residency, and then there's an extra year of fellowship, and people are going to question you. They're like, why are you doing an extra year to do chronic pain, and so I think it just helps to just I think it'll just help you just overall if you can find a lot of joy in medicine, because I think that's what we all experience, like that we really just like our jobs and like what we do. And so just kind of making sure that you're the best physician and the best person that you can be will help. And that's sort of what I would just tell my younger self is like, maybe stop worrying too much about like where exactly I landed on the curve of that test, and just kind of focus on myself and sort of the patient in front of me.
Dr. Garcia, I love your answer. In a similar vein, I would say like, you want to follow your passion, right? Like the specialty that you choose, make sure it's one that you actually are really passionate about, and let that passion drive like how you get involved in that and how you develop your interest in that specialty. So for example, if you find that your passion is in research or in extracurriculars in that particular field, then follow that, because that's where you're actually going to shine and do your best. So then when it comes time for to apply for residency or fellowship, like you're able to talk about what you did from your heart, because it was something that you cared about, and you will more likely produce a lot more results doing something that you like, whether it's getting involved in society and taking on a leadership position, doing a research project, or just doing a side project, whatever it is, at least you can speak from your passion.
Thank you guys so much for that. There's a lot of medical students on this call, so I'm sure they really appreciated all that insight, and just a good reminder to kind of focus on the road ahead of us and not all the tests that we have to take. We all need that sometimes. So now we're going to be moving into our next section of the webinar, day-to-day life, clinical and procedural insights. So these questions are for Dr. Grovey and Dr. Prasad. So the first question that we have is, what do you enjoy most about your career in pain medicine?
So I'll jump in before Dr. Grovey, since I think she may be tied up for a second. So I'm Ravi Prasad. I'm a pain psychologist at UC Davis in the Division of Pain Medicine. I've been in academic pain medicine for my entire career for 21 years. And I guess there's multiple things that I enjoy, but one of the things that I enjoy the most is the truly interdisciplinary nature of pain medicine. It's one of those places where you really truly need the interventional pain physician, you need the physical therapy, the rehab specialist, you need to have the behavioral health, the psychology, all working together to help patients maximize their treatment outcomes. And so that's one of the things that I find very enjoyable about this profession. Even though there's so many aspects of medicine that are interdisciplinary, this is one of the spaces where you see it all come together on a day-to-day basis. Being in an academic institution, what I enjoy is being able to provide that education to trainees, doing that education for medical students, residents, fellows, and helping them understand the importance of this interdisciplinary approach to care. And then also being able to collaborate with other specialties. We've set up a headache clinic with our partners in neurology, set up treatment pathways for patients with sickle cell anemia with our colleagues in Hem/Onc. And then also being able to do other interdisciplinary collaborations, pre-procedural screening for surgical options with our neurosurgery and ortho colleagues. So there's just so many ripe spaces for collaboration in this interdisciplinary fashion. I would have to say in the field of pain medicine, it's that interdisciplinary aspect that's most enjoyable to me.
Awesome. I would agree with that. I'm Dr. Brittany Grovey. I'm sorry I was talking on mute earlier. I'm Dr. Brittany Grovey. I'm an anesthesiologist by training. I'm in private practice in San Diego, California. I did my training up in the Bay Area at UCSF and then came down to San Diego for anesthesia and fellowship training. Of note, I also I met my now husband in medical school, and we couples matched down into anesthesia and couples matched down into pain as well. And so about a year after fellowship, we started our own practice. So we are completely independent, the two of us doing interventional pain. One of the things I really enjoy about it is the longitudinal relationship I get to have with patients and the conversations I get to have. One thing that I didn't realize before I got into pain management is how much pain affects everyday life, activities, relationships, and how many disease processes also can cause and affect pain. And so I initially thought I was going to go into primary care because I really enjoy those kind of conversations and interactions and getting to know my patients. And being able to go into pain management allowed me to do that while also getting to use my hands and be procedural, which I very much enjoy, while having almost that immediate gratification that you get in anesthesia when you do an epidural and a patient walks out of that office, or you do a nerve block and a patient starts crying on the table because they haven't had relief of their neuropathic pain for years. It's a different kind of experience for me, which I really enjoy. And then I also get to know about their grandkids and the baseball game they're excited to go to after the procedure and things like that. So it's a longitudinal relationship aspect as well as the kind of instant gratification and procedural part that I really like, just practically speaking.
That's amazing. Thank you so much for sharing that. And it's awesome to hear about your power couple story. That's incredible. The next question we have is for Dr. Prasad. Just wanted to expand more on how pain psychology is involved with chronic pain management.
Yeah, well, thank you for that question. Regardless of what the core cause of a person's pain condition, we know that different substances, different stresses, different emotional states can all influence and intensify their experience of pain. So helping patients learn what these factors are and what they can do to control these things is basically where pain psychology comes in. Usually the process that we have is patients have an initial evaluation with myself. In that evaluation, I view it as an intervention in and of itself. Many patients don't really have an appreciation for an understanding of where psychology fits in the realm of pain management. They are asked to see a psychologist in the pain clinic, and all of a sudden they jump to this conclusion: oh, you think the pain is just in my head. You think I'm imagining this. You think I'm crazy. And it's actually nothing further from the truth. The reality is that we're really looking to try and optimize a patient's care. And there's a plethora of data that shows us that early life experiences, depression, anxiety, coping, tendencies towards somatization, all of these things can affect the outcomes that patients have from surgeries, from procedures, and helping patients to address some of these things. All of these things are basically modifiable factors. And so helping patients learn how to address these can improve their outcomes from the procedures that we offer. So the intervention part of the evaluation is helping patients learn about these things and how these things can affect their pain. So in addition to gathering information from the patient about these different variables, I spent a bit of time educating the patient, helping them understand and kind of weaving a picture of how all their early life experiences, their current stressors, emotional state, substance use patterns can influence their pain. I use a lot of different models. I actually keep a model of a skeleton. I have diagrams, things along those lines to help them learn how these things can affect their pain and their responses to treatment, and how the different pathways I'm recommending concurrent with their medical care can help them move into healthier pathways and have better responses to care. And by the end of the evaluation, even if patients were very skeptical and leery of doing the evaluation, the majority of the patients typically say, you know what, I didn't know what this is all about, but I'm glad I did it, and I'm glad that UC Davis offers something like this. And Davis isn't certainly unique. There are many academic medical centers, many private practices that offer that interdisciplinary approach to care. But that's kind of in a nutshell where psychology fits into the overall gestalt of pain medicine.
Thank you so much, Dr. Prasad. That was really nice to hear and kind of better understand, like you said, how it fits in. You did kind of touch base on this, but we did have a follow-up question. Are there any common misconceptions about the field that you'd like to address? This question's either for you or Dr. Groby.
There's a lot of misconceptions, I would say, about pain psychology. And one of the biggest things, just what I had mentioned a couple of seconds ago, that a lot of patients perceive that if they're seeing a psychologist, that the pain is all in their head, or that that they're crazy, things along those lines. And so one of the ways that disabuse patients of that notion is through education. So I spend a bit of time, as I said, explaining this to patients, but I also spend time educating our physicians. So I do a lot of training seminars. I do a lot of didactics for our pain fellows, but then also give lectures at grand rounds and such for other colleagues within the medical center so that they can shape what the communication is when patients are referred to our center or when they talk about pain. Before patients come to a pain clinic, oftentimes they're seen in primary care first. So what's the language that primary care is using to help patients understand how pain is approached and where psychology fits in? That's critical. And so I do a lot of education for clinicians to help address that. But that is one big misconception, that pain is just in a person's head.
I would agree with that. In addition, I think when it comes to pain management, especially with the opioid crisis, a misconception is that one of the first things we reach for are oral medications. So a lot of patients won't seek pain management because they don't want medications. And so I think that's a very common misconception about all of the different things that we actually have in our toolbox. And it's not even just steroid injections. That's another reason someone would be like, I don't really want steroids, so I don't want to see pain management. But there's so many things. There's neuromodulation. We can intervene on nerves, which is incredibly cool and fun. And it's like human video games. So I obviously enjoy doing it. There's sometimes we can even change the structure. So one of the things I think that's important is that we're trying to improve patients' function. And oftentimes patients will wait till they're at the tail end of like, oh, I'm in excruciating pain to seek pain management. But for me, I try to educate primary care providers and our referring providers, hey, when a person starts having functional deficits, even if it's mild, they can't exercise as much as they were able to, send them to us. Let's see if we can intervene early. And so that kind of need for earlier interventions, I think, is also a misconception, that you should wait until the pain is unbearable to come and see us and have a conversation.
Absolutely. Thank you so much for kind of clearing that up and giving us a better perspective from both the psychology point of view and the practitioner point of view. So thank you so much. Our next question in this section is, how do you incorporate, I guess kind of going off what you just said, Dr. Groby, but how do you incorporate patient values, beliefs, and culture background in your clinical approach?
Oh, that's a great question. I actually think it incorporates itself if you sit down and talk with a patient. I think all of those things are in the room with you when you sit down and talk to a patient. And they will become more apparent if you ask the right questions. So one of the focuses when I'm treating a patient or evaluating a patient is, what is it that you want to do? What can I do for you? What are you here for? How would you like me to help? And what sort of just practical things do you want to do? And so it may be, I'm going to give a person a spiel about, hey, you have a bad lumbar disc. You want to avoid things that involve lumbar flexion. It's going to pressure your disc and cause more pain. But if their goal is to be able to pray multiple times a day and prostrate on the ground in that lumbar flex position, then, that may not be the best advice for them. So I think it kind of comes into the room if you ask them what their goals are, and what they would like from you and how you can best help. And I think just being mindful that one should ask those questions in the initial evaluation so that you can create a treatment plan that's specifically tailored to what that patient wants to do, because their own goals will kind of focus around their values and their needs and cultural differences, and I may not need to understand it to be able to help them function within their goals.
Thank you so much for that. That's very insightful. And I think that's advice that we can even apply day to day as medical students on our rotations. So good things to keep in mind. We're going to be moving on to the next section, which is building your career, and talk a little bit about research, academics, and private practice. So this next question is for either Dr. Grovey or Dr. Cece. What advice do you have on forming relationships within medicine, and how have you leveraged these relationships?
I'm happy to pop back in again. So being in private practice, it has been incredibly important to form these relationships because these people become your referring providers. They become your source of patients. And so I think that one thing that's important is knowing who you are. Not just your practice mission statement and your practice mission, vision, and values, but your personal mission, vision, and values. And then you want to go out and you want to meet these people. You want them to know who you are as a practitioner, especially in private practice. That's very important. And I'm in a competitive market like San Diego. And so putting boots on the ground, doing your market research, who's in the area, and industry can really help with that as well. I think that's when our industry partners really shine because they can pull CPT codes from primary care doctors or surgeons in your area that may have patients that have the kind of disorders that you have, that you specialize in. But the big thing for me is to know who you are. Have a niche, know what you do that separates you from other people in your area, and make sure you feel confident and strong in that, and go talk to people and they will feel your passion.
And I'll add from a different perspective. So like when you're starting out, like whether you're starting out as a early in your career as a resident fellow, and you're realizing like you want to do pain medicine, start building relationships early from that point. Even now as a med student, like go to societies, talk to people who are in this field, start building relationships. Because then once you reach the point where you're a fellow and you start looking for jobs, they can help you with that, or just overall support on what direction to take your career, because there's multiple directions you can take once you whether you go the private practice route or academics, or there's even private academics and hospital-based groups, and it's like, how do you know what to choose, or would you want to pivot at any point? So it's good to have built-in relationships ahead of time and develop a lot of mentors so that you have a lot of people that you can rely on for support to help you get through, because this medicine in general is just not an easy career. And it's really helpful to have like that community support you. And then when you think about where to develop those relationships, definitely society is a huge one. So like getting involved in PSPS, or coming to the conferences and meeting people, and just people in your training program, and just making sure that as you go through each stage of training, that you like maintain those relationships that you've already developed, because they're a wealth of resources.
I love that. I just want to chime in really quick. Go to the mixers. Go to the mixers. I know at the end of the days we're like want to retire to our room, but that's where a lot of the kind of casual meeting and connections are made. Go to the mixers.
Absolutely. I know I can speak for me and Akanchita. We've been to a few conferences and it's been super cool to see doctors you see online or things like that, like in a more casual setting. Like, okay, they're humans too, you know? So it's really cool. And like you said, cool to make those connections early on. Okay, so our next question is, this is one is for Dr. Prasad. What new, or anyone, but this one was specifically for him. What new advancements or future directions in the field do you foresee?
This giving an answer to this question is going to really make me look like the old man in the group, probably because I am the old man in the group. When I started doing pain management, they didn't have electricity. But speaking of electricity, actually, neuromodulation, which is electrical stimulation, it's been a treatment option for pain for patients for many decades. But just in the last 10 years, we've seen an explosion in this technology. There's a number of devices offered, including devices by our sponsor tonight, Natalie Medical. But now we have different forms of neuromodulation therapy to offer patients. There's dorsal root ganglion, DRG, high frequency, peripheral nerve stimulation, things that weren't available years ago, things that weren't available when I was doing my fellowship. We also have treatments or pathways to specifically treat atrophy of the multifidus muscle, things that weren't available years ago. And these are all advances that we see with neuromodulation. Also, patients that have findings on imaging and have been offered surgery, but are wanting to avoid surgery due to either age, because of medical comorbidities that make surgery risky, or just because of personal preference. They're now minimally invasive alternatives, such as minimally invasive lumbar decompression, which interventional pain physicians can offer. And also for vertebrogenic low back pain, there's also basivertebral nerve ablation. So these are all technologies that have come out recently. And if we've had such a proliferation of advanced technologies just in this recent past, just in this last decade, I can only imagine what the future holds as we embrace new technologies such as AI to help advance patient care. I mean, it's really a very exciting space to be for an interventionalist. And as a psychologist, I can understand that there are multiple factors that can optimize treatment, as we talked about before. And so that's something we'll actually talk about at a June webinar that we're going to have. But all these different advancements are something that's really exciting, not just for the interventionalist, but for myself as well. It's really exciting to see where the field may be going.
Thank you so much for that. We just wanted to announce that there's a few people that are raising your hands to ask a question. If you can type that into the chat, we'll get to those shortly. So the last question that we have for Dr. Grovey is, how do you see your career in pain medicine as supporting equity in healthcare?
Well, I think that, and there's a lot of different fields which have like disparities in care, and pain management is not the exception. There have been a lot of research. I think some of the saddest is in children presenting to the emergency room, where the color of your skin dictates how much pain medication you're getting for standardized injuries. And so in pain management, we still have some ways to go. In addition, there was a study that came out a couple of years ago that showed that there's disparities in care based on ethnicity with spinal cord stimulation. And this is controlled for insurance. So these all Medicare population, they all have access to the therapy, but there's still a discrepancies based on ethnicity. In addition, a lot of our patients are people who are considering total hip, total knees, spine surgeries, and there are also some disparities when it comes to those procedures in eligible patients when it comes to ethnicity. And so I think that as being able to have those longitudinal relationships with patients, you have a certain trust with them. And if you've been seeing them for a while and you've done some kind of successful procedures and they trust your expertise, they trust your judgment, your knowledge, then you can have these conversations about kind of the more advanced, more slightly, although still minimally invasive procedures that may benefit them. I've also have conversations about people who are considering getting a total hip or a total knee or spine surgery, and they want to have that kind of trusted advisor on which way they should go. One of the reasons that some of the studies have cited for the disparities in surgical like undergoing surgery is that the patients don't have a good sense of what to expect. And so they think that the pain is going to be more post-operatively. They think that the complication rates are higher. And so being able to have those conversations with a trusted provider, I think can help as a one-on-one to help reduce those disparities. In addition, I just think that pain affects people's lives in such significant ways. It affects mood, it affects function, it affects relationships with your families. And so being able to touch people in those ways as well just helps them be kind of happier, more productive members of society. And it's just been a blessing to be able to give that gift to patients.
Thank you so much, everyone, and Dr. Gurry for the amazing answer. We're going to move now into the question and answer portion. That was the last of our kind of predetermined questions. So we'll go ahead and start with an anonymous question that states, what sets interventional pain management apart from other pain management or medical specialties? And anybody can answer.
I think the injection component of things. I love injections. And so it's kind of my reach to even before considering medications, because medications have systemic effects. And with current pain management, there are so many different interventions that we can reach for in our toolbox now. And so I think that's what separates us. And there's even, I think, going to be in the future even more so of a divide of those who do kind of the standard pain management procedures like epidurals, nerve blocks, ablations, and those that do kind of the more minimally invasive spines like spinal decompression devices and things like that. And so I think that's what separates us is actually getting in there with your hands and potentially changing pathology.
Thank you so much. I know Dr. Prasad kind of touched on this, but a question from Anthony Daniel: with AI integration and imaging advancements, how do you foresee the scope of interventional pain management evolving in the next decade?
I'll defer on that question to my colleagues who actually do the interventions, because they probably have a better ability to answer that question. Dr. Grovey or Dr. Seat, do you have a?
Okay. Yeah, so I think that AI integration is going to probably help with our diagnostic accuracy. I think it's going to be somewhat difficult to change, to take over our actual hands doing procedures. But I think that we're going to end up being a little more standardized in our approach, and that's going to give us more data and better data to support some of the things that we do. So that's what I'm hoping. That's like a selfish hope that AI is going to help us with, is kind of standardization of practices, so that we can really advocate for these interventions that have successful outcomes.
And then to add to that, some people are using AI in their clinic just to help with like taking notes. That way they can pay more attention to the patient, and then hopefully that like AI can cut down on how much time it takes to like get all the documentation, billing, coding done.
Thank you guys so much. Next question is from Nolan Miles. In what ways can interventional pain specialists ethically navigate patient demands for procedures that have limited long-term efficacy?
Okay. I feel like I'm talking a lot, so I would say I talk to patients that I don't have the expectation that our procedures are going to have long-term efficacy. My kind of spiel with them is that my job is to help you be able to do the things that are going to have the more long-term efficacy, the physical therapy, the aqua therapy, that are actually going to, help change things over the long run. But how effective can physical therapy be when the patient can't participate fully? And so I always have the conversation. A lot of times I'm not changing the pathology, and my injections are not going to last forever. But what they are designed to do is to help you in this short window of time to be able to retrain your body, retrain your brain, because we know there are central nervous system changes that can also be modulated when people are able to get out of pain. We see that. And so I don't tell them to have the expectation of long-term pain relief. This is a journey we're on together, and they're going to have to be active in it.
And to add to that, I think that this is really a place where we illustrate that benefit of interdisciplinary pain medicine, beyond the physical therapies that help maximize the outcomes. This is where a lot of the psychological variables come in place as well. Somebody goes in to have a procedure, but they have exceptionally high levels of depression, exceptionally high levels of anxiety, strong tendencies towards somatization. There's literature that shows that those folks typically aren't going to fare well from an outcome perspective. And that's outcome in terms of their overall return to function. As Dr. Grovey said at the earlier on in the presentation, one of the things that we try to focus on isn't necessarily pain intensity as much as how can we get people functioning more? How can we get people back doing the things that give them quality of life? And so to maximize the gains that people get, we want to make sure that we're addressing, concurrent with the procedures, all of these other psychosocial variables that we know that can affect their responses to those treatments. And so I tell patients, it's not an either or thing. It's not that do the psychological treatments instead of the procedures or do the procedures instead. It's a combination of those things working together that's going to help them get to a better place.
I'll also quickly add one thing. By the way, I should say that two things. The panelists, amazing answers. Definitely believe in the philosophies. But in response to that question, we also have to think about the evolution of the field. And this is the beauty of this, everybody, is that we are becoming more what they call destination therapy driven. In other words, there are certain interventions that did not exist. Dr. Prasad said earlier about some of the advancements in interventional pain management. Now we have neuromodulation that's making a meaningful difference long term. Basivertebral nerve ablation, long term results. SI fusion, long term results. So we can use these interventions from a diagnostic standpoint, as Dr. Govi mentioned about the nerve block and people having significant relief temporarily, no question about that. But this could also bridge us to something that will cause relief long term too. And the benefit of a society like Pacific Spine and Pain is that the fact that we collaborate with different fields to be able to, like I said before, leverage each other's strengths, learn from each other to help improve outcomes long term.
Thank you so much. There's a couple of questions that I'm just going to go ahead and combine that are coming in from the students. And one of them is, what's the typical training path to become an interventional pain specialist, and what subspecialties or fellowships best prepare someone for this career? How competitive is the field, and what qualities make a strong candidate?
So I think I'm the one that's closest to this, seeing as I'm a pain fellow right now. So you have to complete medical school or osteopathic school and then do a residency. Typically, it's 3 to 4 year residencies. Your primary specialty can vary. So we do have applicants from like emergency medicine, psychiatry, family medicine, as I had mentioned before. One of the most common fields that apply into pain medicine fellowship is anesthesiology and physical medicine and rehabilitation. And then after that, you have a 1 year fellowship currently in pain medicine. Things can definitely change. There's some talk about prolonging the fellowship, et cetera. But that's the way it looks like right now. In terms of competitiveness, so it all goes up and down. And so you'll find, I mean, when I was in medical school, there were some specialties that were more competitive at that time that aren't competitive at this time. So things can definitely change. In the last few years, I think pain medicine has been a little less competitive. So we're kind of on that downward kind of slope right now in terms of competitiveness, but things always change all the time.
Does anyone want to touch on what kind of qualities would make someone a strong applicant?
I think it's the ability to communicate with people because our chronic pain patients, right, are in really challenging spots. And so you to be able to build a really good relationship with them, you have to be able to communicate, to answer their questions all effectively. So you have to be empathetic, compassionate. The technical skills, people tell me you can always like learn them as kind of you go along. I mean, obviously, a little bit of maybe just at least enthusiasm for those skills is really necessary. And then overall, you just want someone who's going to be a good physician because, as Dr. Grovey had mentioned earlier, right, you're seeing patients kind of for the long term, and there's so many different diseases that they have that can impact their pain. And there's just so many medications that you can try them on that can interact with other things. So you really just want to be a just good physician.
So thank you so much, Roxy, for that answer. The next question is from Neon Panda, and it is, what institutional or policy level changes could better support career growth in this field?
I can speak on that a little bit. I think that some of the more, like as Dr. Cornitas was saying, some of the more destination therapies, like for example, SI fusion, peripheral nerve stimulation, um, are having some difficulty with some of the payers and reimbursement. And so I think a lot of work is going into um, trying to advocate to have these things be considered a standard of care. And so unfortunately we're, money talks, and we're in a society where you can't do something if it's not paying. And so if private insurers, which make up a large part of the market, are deciding that a certain intervention is investigational and refuse to reimburse it, then we aren't really able to offer it as readily to patients. And so I think a lot of focus is going into lobbying on Capitol Hill and the RUC committees, who kind of assign the like RVU values to these procedures, as we try to get more information and more data to allow us to increase the access destination, more kind of minimally invasive surgical procedures.
Thank you so much. There's a question submitted from Nomad. In what ways can interventionalists influence health system policies around chronic pain and opioid stewardship?
All right. I think being active in societies, because a lot of the societies do have a component where there's an advocacy and policy. So people are writing papers to journals in responses to like negative publications, for example, about like lumbar epidural steroid injections. People are trying to coordinate multi-center kind of data collection to try to support the procedure so that we can present these to, Capitol Hill and also to the private insurers. And so I think being involved, practicing the right way, getting involved in society, and showing your enthusiasm for it, people will bring you in like no other, because there are a lot of things in our field right now that are under a lot of scrutiny. And so societies are really expanding their kind of advocacy and policy committees to help support what we do so that we can continue to offer these therapies for patients.
Now, I'd quickly add to that too, jumping back to that whole concept of interdisciplinary care, partnerships with other individuals. Certainly at our institution, we've partnered with our pharmacist to provide guidance around opioid stewardship, and we're able to really help a large swath of our primary care clinicians, a large swath of our patients who are dealing with opioid-related issues, while being able to still provide interventional care, psychological care for pain management. So it's trying to break out of the silos and doing this work and collaborate with other specialists who are also dealing with similar issues, but perhaps from a different angle, so you can work collaboratively to try to help make an impact.
Absolutely love to hear about all the ways we can work together. So we're going to ask one more question. It's from Dominic Chase. How can interventional pain physicians become more involved in shaping public and academic discourse around pain?
I definitely think it's being involved in these societies and doing the research and advocating. And I think there's also a big like public speaking component to it as well. And that can take the form of like social media or just articles that people write. But I think there's a lot of misconceptions about pain from other physicians sometimes, but also from patients themselves. And the field has changed so much that it's really hard, I think, to measure sometimes these outcomes. Like we haven't found a great way of doing that. But I think it's also just really hard to disseminate information. So, like, even if you don't want to be the biggest researcher out there, at the very least, just like making sure that you make kind of that information available to yourself, even if you're like a pain provider, just even going out to like primary care physician offices or networking with other physicians to tell them about what you do and what you can offer. That helps a lot because there's a lot of people both within uh, medicine and outside of it that don't have a full understanding of what pain medicine is.
Perfect. Thank you so much. I'll go ahead and hand it over. Yeah, go ahead, Dr. Cornelius.
Amazing dialogue, amazing participation. This was a great webinar. Just a few more things, y'all. So I know that many of you who submitted a survey, they want to know if you got $100 out of this. So we're going to announce that here in a second. Just a few things. There are 3 QR codes that you see there. The first thing is the one on the left, and that's another webinar that's hosted by our own Dr. Ravi Prasad. I love everything he said, and so I'm pretty sure this webinar is going to be an amazing one as well too. If you want to participate in that, please scan that QR code and get on it because it's going to be a good one. The one in the middle is more about PSPS. You know, what does this organization have to offer? But even more importantly, how is it that I can contribute to something that's much bigger than myself? And so we heard many of these responses and questions. You know, the answer to a lot of this is get more involved, meet people, collaborate, develop these relationships. There's so much that you could do, not just to contribute, but also gain. People who've been in the space for a while, you could tell that we love mentoring, we love coaching. Our ultimate goal is to find the younger generation and make them better than ourselves. And PSPS is definitely involved with that. I highly encourage for all of you to be a member. It is completely free, and it'd be nice to be able to introduce you to some power hitters in the space to get you up and going. The last one that you'll see there is our post-webinar survey. We really appreciate your responses for the pre-survey or the pre-webinar survey, and we just want to obtain some more information to, again, see if this webinar made an impact. Based on the participation that I see here, I'm pretty sure that we're going to have another one. And so we're really excited about shaping these webinars to fit your needs and to make sure that you get as much out of it as possible. So please participate in that. Speaking of other future events, if you want to hit the next slide, Rosa, I want to talk about the very, very exciting annual conference. And this is going to be in Vegas, baby. So get ready for that. It'll be at the Venetian Hotel. This annual conference is just a best of all worlds, right? You go in there, there's so many different lectures and discussions and Q&A sessions that really talk about not just the foundation of interventional pain management, neurosurgery, orthopedic surgery, pain psychology, physiatry, you name it. Great foundation, but also, and more importantly, how do we use that to make the space better, right? How do we get a great solid foundation and continue to improve, innovate, use of AI, et cetera, to make the space better? Because ultimately, we're here to serve our patients and to make a meaningful difference in their lives. So that's one aspect of it. But the other thing too is just the networking, your ability to shake hands, to get to meet future mentors of yours. So definitely take advantage of that. And it's my wheels are turning right now. I'm anticipating that somehow we're going to figure out a way to sponsor a few of you medical students to be able to participate in that as well too. Trust me, you want to join PSPS, and little by little, we want to get you more connected, to these potential opportunities.
Can I just really quick, I'm sorry, but
Please do.
piggybacking off of Dr. Cornita's and the PSPS annual conference, you guys, it's such an approachable society. So I know you have a lot of different choices with what societies you want to join. And my plug for PSPS is that it is so approachable. All of these like big names in pain management are just right there. You can touch them. It's a regional society. We're pretty small. And I just think that it's a place where people come, they unwind, they relax, and it's very big on just mingling. Getting to know people. And so it's not like the huge conferences where you feel where it may be a bit overwhelming, like where do I go? Who do I meet? Like if you come to PSPS and you come to one of our mixers, you can meet anyone and everyone. And so that's what I really like about PSPS is it is approachable. We want people to get involved. We were talking about creating medical student tracks. Like we want you guys involved. And so we want to bring you in. So that is my plug for PSPS over some of the other pain societies.
And if I could, one quick thing too, just related to the post survey. I know everybody is so tired of surveys. It's exceptionally brief. I think it's like all of 3 questions. And so I'd really, really appreciate if you guys could take the time to just fill out those very, very brief 2 or 3 questions that we have in that post survey.
And last but not least, well, before we do that, let me just give another shout out. Last slide for Nalu, again, neurostimulation company. Thank you so much for your active participation and really your partnership to again leverage each other's strengths, minimize our weaknesses to make patients better. So, and I know what you all are wondering, who is the winner of the survey? And so we tallied it up. And I want to announce that Abigail Mendoza, she's our winner of the $100. So congratulations and thank you for participation. Again, I can't thank everybody enough for their participation, the panelists, the medical students. I mean, you all did amazing. So very, very happy with this webinar. I really think it's going to be what it's going to be in the books because it's one of the best ones that I've participated in. Thank you all. You have a great night.